to handle a patient with ITP, which is different to what we had in the agenda, but never mind. Thank you. Thank you, Drew.
Thank you for that lovely introduction and reminding me of my age. But anyway, good morning, everyone. Yeah, the title is slightly different, but it's really just how we approach someone with ITP and why we do the tests we do, and also what we're thinking when we decide on treatment, or maybe we don't give any treatment. But a low platelet count is incredibly common. I mean, loads of people have it. Many people have it and they don't even know. GPs see it a lot. We see it in hospital. We see it on the intensive care unit. And it's really one of our most common referrals to the general hematology clinic. But having a low platelet count is not a disease. It's like anemia. Anemia is not disease. It has a cause. And our job really is to find the cause. And ITP is one of the causes of a low platelet count. So the questions for us really is, number one, what is the cause of your low platelet count? That's what we work on initially, to try and get a diagnosis. And only then can you decide what to do about the low platelet count, if anything. Sometimes we don't do anything, but what do we need to do once we get to that stage? So the cause, and sometimes people, it takes a little while when you go to see your family doctor and then he does some tests and then you go to hematology and we do more. It can take a little while till we actually nail the cause. And it can take, it can be tricky working out what it is. But the causes of a low platelet count, and I'm not going in detail here, but the three main ways your platelet count could be low is if your bone marrow is not working properly, and there are lots of causes of bone marrow is not working quite right. You're not making enough. If you're destroying them too rapidly, which is like ITP, the platelets are there, but they get killed off fairly quickly and your bone marrow can't quite keep up with the rates of destruction, or your platelets are hiding away somewhere. They're ending up in an organ like the spleen, for example. So your total number of platelets would be normal, but they're all hiding in the spleen or somewhere else. So in the bloodstream, they appear to be low, but your total platelets are pretty normal. So in medicine, what we do, of course, all good physicians should take a good detailed history from you, and you will have been asked lots of questions when you first go to the clinic. After we've taken the history, we have enough information, we then examine you to see if there's anything we can find that might point towards a disease which might be causing your low platelet count. And then we do some basic blood tests. So the history includes, and there are more questions than this, but we want to know if it's just you or maybe someone else in the family has this problem. Have you got any bleeding? Where are you bleeding? Is it from the nose or the mouth, or is it just bruising? Have you ever had an operation in the past? Was that straightforward, or did they tell you bled abnormally? Or maybe you had a tooth extracted. Was that normal? Did you just bleed for the normal time and that was it? Or did you bleed for a long time? Have you had any recent infections which might have triggered your drop in platelets? Have you had any vaccinations, like the COVID pandemic, COVID vaccination we were talking about during the adult breakout session? Are you pregnant? Or what about pregnancies? Were they uneventful, or were your platelets low in pregnancy? Have you been anywhere exotic? Could you have picked up malaria or other tropical diseases? Any blood transfusions? Do you drink alcohol? How much? The bone marrow does not like alcohol. Binge drinking is not great for the bone marrow. What's your diet like? Are you taking any drugs? Drugs can commonly cause your platelets to drop. We need to know every medicine you're on and the supplements. And then we work out the risk factors for things like HIV. So we do the history and then we examine you. General examination, the patient, do they look well or do they look unwell? Have they looked like they've lost weight? Could they have some underlying disease which might have resulted in the low platelets? We obviously examine you for bruises, particular hemorrhages, purpura. We should always look in the eyes with an ophthalmoscope because sometimes people can bleed inside the eye at the retina. I think we're slightly lazy these days, but we should really, when someone has a very low platelet count, we should be checking the eyes. And then we examine you for lymph nodes because some things like lymphomas and other diseases bring your lymph nodes up, or infections give you big nodes. Can we feel the liver? Is it normal? Is it big? Spleen, is it normal? Is it big? So this is all basic medicine, general physical examination. So we've done the history, we've examined you, and then we need to know more about the platelets themselves. So we move on to the blood testing. You may have come from your family doctor with a low platelet count, but is that just a one-off? Because sometimes we repeat it and it's normal, in which case there's no point doing anything more exciting if your platelets are normal. Confirm that it's real. We have to confirm that it's real. We do a blood count and we do a blood film or a blood smear. We look at it under the microscope. We look at platelets, we look at red cells, and we look at white cells. We have to look at everything because there are many diseases which will show in the peripheral blood smear, which give us clues as to what the underlying condition is. So do the white cells look normal? Do the red cells look normal? But there is still no actual test for ITP, which is really depressing as Dave went through the history of ITP. We're here now 200 years later, and really we haven't got much more in terms of diagnostic tests than we had way, way back, which is depressing. It's still a diagnosis of exclusion. We must rule out many, many things. And at the end, we'll say, well, we can't find any evidence of cancer or of deficiencies or bone marrow infiltration, etc. So it's ITP, and that's not very satisfactory. So here's a blood count. This is the peripheral blood count. That's the comment on the film. You'll see the platelets here are very low, and it gives you the other readings for hemoglobin, white cells. And then someone has commented on the film here saying that the blood film confirms the low count, i.e. when they look down the microscope, there are not many platelets to see. And here's the blood smear. You can see on the left, there's the glass slide with the blood smeared on there. This is a normal blood film with a neutrophil. You can see the platelets being pointed out here with the arrows. And this is ITP, where there are no platelets to be seen. These are all just red cells. We should always look at a blood smear. It gives us lots of information. And then we have this strange condition called pseudo-thrombocytopenia, false thrombocytopenia, a falsely low reading on the counter. The platelets in certain anticoagulants that we use in the bottle, the purple bottle, that can clump together. So your platelet count in your bloodstream is normal, but when we put it into a bottle, they clump. And the machine reads the platelets and thinks they're low, but they're not low, they're normal. This is a false type of thrombocytopenia. We must exclude this. We look for inherited disorders with giant platelets or very tiny platelets. That gives us lots of information. We look at the white blood cells. There are conditions called myelodysplasia, which is more common in the elderly, dare I say, my age group. Viral infections where the white cells are attacking viruses and got funny shapes, so there's no platelets there. And then leukemias, of course, as well, because it infiltrates the marrow with abnormal cells. So we look for these conditions on the film. So we've done the history, we've done the examination, and then we do some fairly basic blood tests. We measure your antibody levels, we do your blood group, we check for viruses. Occasionally we do a bone marrow, not very often nowadays. We do a direct antiglobulin test, and I won't go into that here. And sometimes we check for this bacterium, but not so much nowadays. So it's very, very, very simple investigation for ITP. Now, talking about bone marrow, some of you may have had a bone marrow. We very seldom do them now. If it looks like ITP, we treat it as ITP. If there's anything suspicious, if your blood smear is not right, or you've got weight loss, or maybe your liver's big or your spleen's big, we may then do a marrow. If you don't respond to our treatment, we may then do a marrow. But most people don't have a marrow. Even if you're really elderly, you don't have a marrow. So what we found so far, you've got a well person, they feel fine, they have a low platelet count. They have a bit of bruising, but they have no bleeding. Maybe they've got some little particular hemorrhages on their shins, and there's nothing to find on the physical examination. The repeat full blood count that we did confirms the one that the family doctor did, and it's a real low platelet count. So it looks like ITP. So what next? What do we actually have to do for you? Well, this is the big worry that people have is bleeding. Bleeding into the brain, for example, which is not very common, thankfully, but it does happen. And because all these things are very unpredictable, it tends to cause people to be overtreated. Physicians are worried that a patient's going to suddenly have a bleed into the brain. So that has led to overtreatment over the decades. But patients are more bothered by things like their energy levels, and anxiety and depression is very common with ITP. And also the cosmetic effect, the bruising. Some people are embarrassed if they work in the public facing jobs and they've got bruising all down their arms. It looks bad. But who's at the highest risk? Well, I've got a few pictures of bleeding here. This is on the left, widespread purpura petechiae in a patient that I had years ago, went right up to the abdominal wall, a very dramatic presentation. Here's someone with a spontaneous bruise, pretty spontaneous bruise on the abdominal wall, big bruise there. Platelets were less than 10,000. You've got bleeding into the mouth, blood blisters. We often worry about these blood blisters that people get here. And then this is the hard palate in the mouth there as well. Now, this is slightly controversial, and maybe Fred will pick up on this later. There is a thought that older people have a higher risk of bleeding, but some data from the French group, in fact, shows that age may not be a factor. But the way we understand it kind of is that your bleeding risk if you're under 40 is quite low. And then once you're between 40 and 60, this is non-fatal, this is fatal. And then once you get to over 60, it goes up dramatically. But there are some data coming out from registries that say that maybe older people are not so much at risk of bleeding. And the platelet count doesn't really tell us what's going to happen. Not really. This is bleeding here on this side. So that's really bad bleeding. This is no bleeding. And this is normal platelets, and this is no platelets. So when your platelets are good, there's hardly any, there's no bleeding. And then as the platelets go down and down and down, bleeding starts to become more common, and it's slightly mild bleeding and then more severe bleeding. And this is the really, really bad bleeding here, which only happens in this study when the platelets were less than 10. But lots of people have platelets less than 10 and have no bleeding at all. So it's a very strange thing. But the platelets really don't tell us what's going to happen to you. So anyway, what would the action plan? Sometimes we watch you, sometimes we bring you into hospital or treat you. We're more likely to observe you if you're well, if you're younger, if you've got no other serious diseases, if your platelets are more than 20, if you're not bleeding, and we categorize you as low risk, then we're happy to watch and wait. However, if you're unwell, if you're older, if we think something else is going on and we can't quite pin it down, we may well bring you in. If you're bleeding, or if we think you're very high risk of bleeding, we'll probably bring you into hospital and or treat. If you've got serious diseases which might add to the bleeding risk, if your platelets are very low, or if we categorize you as high risk. So the options for treatment, the goals that we have are to give you something for you specifically, individualized. We want to prevent bleeding. We're not going for some magical normal platelet count. Something around 20 to 30 would be fine for most people. Try to avoid toxic drugs and try and improve your quality of life. Try and maximize your quality of life. That's the goal. But patients and doctors really have different goals. We're going for the platelet count, safety, preventing bleeding. What you want is control of the count, not a normal count. You want it controlled. You want to prevent it getting worse. You want stability. You want more energy, and many people are happy, many patients are happy with watch and wait. So the options we have is we do nothing. We observe you in clinic, check your blood from time to time. If the platelet count is in the safe zone, and that's preferred by many people. And I would say the best treatment is no treatment if possible, but sometimes we have to treat. Steroids we've covered already today. Dr. Kuta discussed steroids. We still use steroids a lot, but we have a maximum dose now, 80 milligrams, and we try and use it for a short course. But most people, when they come off steroids, will relapse. So what do we do next? We've already talked in the adult session, the adult breakout session about immunosuppression. These are the old drugs. I'm not going through these. There are many old drugs. They all come with lots of side effects. They're not particularly great. There's no evidence. They've never been in trials. These are just used because they were around and it's all we had. We much prefer non-immunosuppressive therapies, especially having had this pandemic. We try to avoid things that will lower your immune system. So hence the thrombopoietin receptor agonists became much more prevalent during the pandemic. We use a lot more eltrombopag, romiplostim, and of course we have avatrombopag now. These drugs stimulate the bone marrow to make more platelets. They do not suppress your immune system. They are safe and well tolerated. They work incredibly well. The efficacy means that 8 out of 10 people, or maybe even more, will respond to these, which is very different to the old azathioprine, mycophenolate, rituximab. These are way better than the old drugs. The platelet counts go up beautifully. Bleeding, if they have any bleeding, will go away. As I said, there's no immunosuppression, and quality of life from the studies so far shows that patients feel much better on this type of drug than they do on azathioprine, mycophenolate, the old non-evidence-based immunosuppressant drugs. And then there's the added bonus that 1/3 of patients who have a TPO like eltrombopag or romiplostim and probably avatrombopag can taper. This is for romiplostim. 1/3 come off. You taper slowly, come off, you're on no treatment at all. The same is true for eltrombopag. The same will be true for avatrombopag, but it's very hard to predict who's actually going to come off. So when people say, will I be on this drug for life? We always say, well, there's a strong chance you may have to take it for quite a long time, but 1/3 of patients do come off. Even if you failed 10 prior therapies and then you respond to one of these drugs, the chances are good that you will come off. So just to wrap up, low platelet count is incredibly common in the population, in hospital, general practice. ITP is not common, of course. We investigate most patients as an outpatient if we can. We don't want to bring people into a hospital because then you get exposed to other things. And we won't bring you in unless you're unwell or if you're bleeding or we think there's some serious underlying disease. Then we'll bring you in and investigate you as an inpatient. The treatment is pretty urgent if you're actually actively bleeding or you have very, very profound thrombocytopenia. But many patients with ITP don't need any treatment at all. And as I said, the best treatment is no treatment. But if we absolutely must treat, and we do, there are times we do have to treat some people, try and use something that works well and does not make you feel worse than before you started treatment. And the newer drugs coming through are much, much better, much more gentle on the body, and patients can tolerate these much better and they return to normal life. Hence, the quality of life is much better. So I will leave you with that. Thank you very much.
Thank you, Drew. That was a really good summary. I would say you may have noticed some of Drew's graphics there. He's now got a second job making pictures of graphics. So if you'd like a picture of the molecule of romiflostin on your wall, Drew's the man to go to.
It's fine. All available from my website.
All available from his website. So if anyone, we could have time for a couple of questions before we go on to Nikki's presentation. But there will be plenty of time for Q&A at the end of the session.